Okay, so ready?
Yeah, yeah.
Let's get started. So thank you guys for being here, and thank you remote users for being with us on WebEx. Today I have the pleasure of introducing Dr. Scott Quinlan, who is a faculty member in our department. He's been here close to 5 years, I think, right? Teaching a range of graduate courses, including both intro level and advanced epi and biostat courses. Dr. Quinlan graduated from our department with both his MS and PhD in epidemiology. And since graduation, he spent more than 6 years serving as a consultant and project manager for a consulting company that worked with pharmaceutical and biotech clients to design and implement studies to assess the safety of new drugs and vaccines. Prior to that, he's worked for 6 years prior to that in a large clinical network in type 1 diabetes, serving with our own George Washington University Biostatistics Center. So I'm going to hand it over to him for his presentation.
All right, great. Thanks, Joe. So thank you all for coming out on this Spring Friday to hear me talk about instrumental variables. So the purpose of this talk is to introduce what I mean by instrumental variables. As Joe mentioned, I worked for a little while in consulting for pharmaceutical and biotech clients about safety and effectiveness of new drugs and new vaccines. And one of the challenges with those is once a product's on the market, it's prescribed for a reason. And so it's very hard to then do comparisons that are fair and that allow us to really see what's safe and what's not, or what's effective and what's not. And so there's a lot of tools we try to use in what we call pharmacoepidemiology, and one of them is instrumental variables. So I'll introduce that topic for you today. We'll start out with a few just ideas, examples where this topic and this approach has been used. We'll talk in general about the problems we run into with observational real-world research. We'll talk about some of the other things that I previously presented on, like propensity score, and where we struggle a little bit with propensity score and what we can't do. And then we'll go pretty basic through what is an instrumental variable, what are the requirements of an instrumental variable, and then we'll talk about some examples, and then wrap up with kind of some limitations and some opportunities based on what we'll present. So we'll start with just some simple examples, and these are some of these are older studies, some of them are very recent, that used instrumental variables, and so I thought we would use those as a way to kind of highlight the way this method works. And so one thing, and this is an older study, but was really one of the first ones that used instrumental variables, was they were interested in seeing what effect smoking has on birth weight. And so we all know, obviously now, smoking is not good for infants, and birth weight, it tends to be lower in those who smoke than those who don't. But years ago, they wanted to compare this, and so they thought, well, the ideal would be to do a randomized trial if something was ethical, right? We can't do that, right? We can't assign some pregnant women to smoke and others not and see what happens. The other option would be to do like an observational study where we look at women who smoked during pregnancy and those who didn't, and then compare their infant's birth weight. But the problem, as we can imagine, is women who smoke are also likely to have other adverse health issues, things that we can measure, some that we can't, that would potentially describe or impact their infant's birth weight. So it's very hard in an observational setting to study something like this as well. This is a very recent use of this method, was looking at the high-dose flu vaccine. So the high-dose flu vaccine was released a few years ago, and it was recommended for the elderly, high-risk populations who needed a little bit of extra protection against influenza, and so particularly in the elderly. And they're interested in knowing, well, does it work? Does the high dose really benefit those who get it compared to those who get the regular dose? And interestingly, in randomized trials, it was shown to be highly effective. And so again, the idea is they did trials. Some got the high dose, some got the low dose, and what they found was, yes, it does appear that the high dose does a better job of protecting people from getting the flu. But the question whenever we do a randomized trial is, how is that going to work in a real-world setting where we're not able to control so many elements? And what they found, interestingly, is that most observational studies that they've done have shown no benefit of the high-dose flu vaccine. And so what's going on, right? We're trying to think about, well, what might be some things that are impacting this, and why did we see a benefit in randomized trials, but in some of the early observational studies, there doesn't really seem to be a benefit. And the last example we'll go through is also a little bit older, but is still very relevant, is looking at selective Cox-2 inhibitors. So these were a class of NSAIDs that were brought out late 90s, early 2000s. Vioxx is the most known example for bad reasons, I guess, but there's also one still out there, celecoxib is another one. And the thing about these Cox-2 inhibitors is they're meant to treat pain and inflammation, but they're also, one of the problems with regular NSAIDs like ibuprofen and these types of things is gastrointestinal complications, particularly for people who are taking these drugs long term. And so Cox-2 inhibitors were meant to give you the pain and the inflammation reduction without the gastrointestinal side effects. And in randomized trials, for the most part, they were shown to be really effective, and that the people who took these Cox-2 inhibitors showed less gastrointestinal problems than those who didn't. But again, the conundrum is when they actually started to look at this in some real-world settings, they found that actually the risk of GI complications was higher in people taking Cox-2s than it was in people not. So, what was going on here again? And so we'll talk about what might be happening in this, and we'll go through this example as well. All right, so the challenge again, and this is what we face in observational research, is that randomized studies are our gold standard, right? There's no arguing that, right? We can, if we can do a randomized study, that's the best way to show that a treatment or a prevention effort or a surgery is the best method. And so it's the gold standard, but we can appreciate the fact that they're not always feasible in all settings, right? We can think about the smoking and birth weight issue. You couldn't possibly consider doing a randomized trial there. Additionally, even if you can do a randomized trial, you run into this issue of generalizability, right? How generalizable, how applicable is what we found in a randomized trial to the real world? And that can be a tough question to answer because the people who are in a randomized trial are often pretty different from others. Observational studies, again, are what we're more focused on as epidemiologists, but the problem we get into there is that there's an exposure selection process. Whether it's a person deciding to smoke or not while they're pregnant, whether it's who gets prescribed a Cox-2 versus who doesn't, who gets prescribed or given the high-dose flu vaccine and who doesn't. So this selection process can make it really hard for us to do fair comparisons as well. And the problem we run into is often those who are exposed are very different from those who aren't. And some things we can measure, other things not so much. And so these are the two issues that we run into in kind of traditional research. Randomized trials are our gold standard, but again, we run into issues with generalizability and feasibility. And then observational studies are great, but the self-selection process that determines who gets exposed and who doesn't can often lead to serious differences between groups, and we can't always adjust and control for everything. So what can we do? So there are other options, right? I've talked about some of these. Here's some that we're familiar with: propensity scores, or other types of matching are done quite frequently. Stratification, if it's something that we're worried about as a confounder. Adjustment during the analysis. So these are all things that we know well and things that we can use to potentially account for some of these differences. But the problem is all of these rely on one thing, and that is we have to be able to measure it. We have to be able to not just adjust for it. For us to be able to do that, we need to be able to measure it and account for it. And some of the characteristics that may lead to these differences we either can't measure or we don't measure. And so the problem that we get into is that even though we've got these methods, they all rely on us being able to measure those differences. And so again, these methods struggle a little bit in that area. So what are instrumental variables? So again, let's summarize where we are. So we said randomization is great, right? That's our gold standard. The nice thing about randomization is that it balances not just those things that we can measure, but also on average those that we can't. And so that's one of the big advantages to randomization, but we said the fact that these aren't always feasible and the results aren't always generalizable. Observational studies, again, we can do those as well, but the exposure selection process can lead to real differences between our groups. And the problem we get into there is while we can measure lots and lots of stuff, there's still things that we can't. Right? We think about a measure like frailty, for example, and how do you really measure that? Right? How do you measure healthy behaviors, things like that? And so the problem is no matter how hard we try, there's still going to be some imbalances there, and that can really throw our results off. So what is an instrumental variable? The purpose of an instrumental variable is to use some variable, and you'll see some examples as we go along, to identify what we call like a quasi-random treatment choice. The idea is to really make use of something that's like a natural experiment and to use that to see what might have happened if we actually could have randomized people. And so we'll go through some examples to show what I mean, but the purpose of these methods, of these variables, is to essentially mimic a randomized situation, where some factor, this variable, led to some people being exposed and some not, and that factor, that variable, is in some ways random. And so it sort of tries to mimic a natural experiment to see what would have happened if randomization could have been done. And so it'll help we go through some examples to see what I mean here. All right, so that's what instrumental variables try to do. It tries to kind of bridge these two. It tries to bridge randomization and observational studies. These are observational methods in the end, but they try in some ways to mimic a randomized trial or a randomized approach in terms of how exposure is assigned. And in so doing, we're hoping we can kind of take advantage of both observational studies and randomized studies and kind of also account for some of the disadvantages of each as well. All right, so what is an instrumental variable? So an instrumental variable is simply a variable that can be used to strongly predict or strongly related to who gets treated or exposed and who doesn't. And so we can think often of this in a mathematical sense, and that this will be very much not a very statistical lecture, but more just an approach measure lecture, where we can think of really two different equations, right? The first one down here that says we can try to model exposure based on our instrumental variable and potentially some other covariates, and try to identify an instrumental variable down here on the bottom that allows us to, in some ways, predict who is exposed and who isn't based on that variable. And then what we try to do is once we've done that, we've created this prediction equation, we then plug it back into the original outcome equation as a way to estimate, well, what is the effect of our exposure on our outcome using this adjustment based on instrumental variables. And so it's typically done as a system of two equations, where we start with the bottom one, where we try to find some variable that allows us to accurately predict who's going to be treated and who's not. And then we use that for second equation to kind of go back to the first and try to see, well, what's the effect of our exposure on our outcome accounting for that prediction. Again, this is usually done in as a two-stage least squares method. There's a whole bunch of other methods that are out there. SAS and R both have procedures to do this. And so, again, I won't focus too much on the statistical piece. I'll more just focus on the application in this talk. But again, this is kind of where it comes from. And this is an instrumental variable. The idea is it's something out there that strongly predicts whether somebody's going to be exposed or not. And that's what we kind of use to account for kind of a randomized process. And we'll go through some examples of that to kind of show you what I mean. And then also show you that some of the problems with this, this approach, is a real balance. There's some real advantages, some real disadvantages, and you'll see that, you can think of some of the problems that we'll get into as we go along. All right, so that's what an instrumental variable is. So the problem with instrumental variables and what I think has really held them back in terms of their ability to help us in observational research is they require three very strong assumptions, and some of them are not easily verifiable. And so as we go through today and walk through these examples, we'll see the problems we get into. And I think instrumental variables, as we'll talk about at the end, have a lot of potential, but there's a lot of things we have to assume, and some of those assumptions are a little shaky. The first one, and this one makes just the most logistical sense, there has to be a strong correlation between whatever that variable is and our exposure of interest. The stronger, the better. Ideally, we'd want a variable that if you're a yes for it, you always get treated, and if you're a no, you never get treated. All right, so that's the first one, the first major assumption. The stronger that link between this variable and our actual exposure, the better. So that's assumption one. Assumption two is there has to be some relationship. The relationship between this instrumental variable and the exposure is not confounded by other factors, which essentially means that if we take this instrumental variable and some people are yes and some people are no, that there shouldn't be differences in patient characteristics across levels of the instrumental variable. And the idea being that really, this variable is random, is what we're kind of trying to mimic, just like we would mimic, in a randomized study, we randomize some people to be treated and others not. We hope that the randomized process leads to balance. Same idea here. The instrumental variable ideally should, if we look at different levels of the instrumental variable, the patient characteristics should be very much the same. And so that's that randomized part. And again, that's another one that's going to be tough to prove. And the last one, and the most important one, is that the instrumental variable cannot be directly or indirectly related to the outcome of interest except for the effects of treatment, whatever the exposure is. So the instrumental variable, the only way it can impact our outcome is through our exposure of interest. And so it can't have other mechanisms and other ways that it might impact our outcome. And so this is the most important assumption and also the one that's the trickiest to figure out. So we'll go through some examples and talk about this last one in particular, because the problem with instrumental variables is, in my view, is that there's just these assumptions are tenuous. And so if they're met, and they are in some cases, you can do this method. If they're not met, it gets a lot more tricky. So you're sort of trading, your assumption of no unmeasured confounders for these assumptions, and so it's definitely a trade-off. But we'll go through each one of these three with some examples to kind of get a sense of, well, what do we mean by these assumptions and how can we prove them? All right, so let's look at smoking and birth weight, and I'll talk about what example they used as an instrumental variable here. So this is an older study. This was from the 80s, but it was one of the first studies that tried this approach. And so essentially what they said was, they wanted to find out whether this intervention program, what effect it would have on encouraging women to stop smoking. So what they did was they had a hospital, they had a whole bunch of pregnant women who smoked. Remember, this is the 80s, so things were a little different than they are now. And so what they did was they randomly assigned these women. One group got an encouragement program where they were meeting with individuals to encourage them to stop smoking. And this was in addition to the usual prenatal care. The other group, the control group, did not get this intense encouragement intervention. They just got the usual prenatal care. So this was a randomized setup, right? Some were randomly assigned to this encouragement program and others weren't. And so again, what they did was the other women were assigned to the other, and what they used, the instrumental variable, was that original randomized assignment. And so what they did was they said, the encouragement, they either were randomly put in the group that was in the encouragement treatment or in the control, and that was our instrumental variable. The hope being that that instrumental variable would predict smoking status, because hopefully if the program worked, those who were in the encouragement group would be less likely to smoke than those who weren't. And so the instrumental variable here was, what group were they originally randomly assigned to? All right, the next one is a high dose versus standard dose flu vaccine. And so again, the concern that they had with this study with some of the observational research were maybe people who were being given the higher dose flu vaccine were being given it because they were already sicker. And so maybe it was, this selective providing of the high dose vaccine to those who had more comorbidities and more risk of outcomes. Maybe that's why in the observational studies we didn't see any real benefit. And so the researchers who looked at this, and I put the reference here if you're interested in more, thought, well, that's the problem, because if we just go based on what somebody was assigned, it could be that those who were assigned the HD high-dose vaccine are less healthy than those who weren't. And so then doing that comparison is not as effective. So what they did was they used data from the Veterans Health Administration to do this study where they use instrumental variables. And what they noticed was that in the Veterans Health Administration, there's a whole bunch of different facilities. And the thing to know about these Veterans Health facilities is each one has a lot of autonomy in terms of their vaccination policy. So they can choose for their facility, we're not going to have the high-dose vaccine, we're going to stick to standard dose. And so they can determine, for their own facility what vaccine they use, who gets which, et cetera. And so, again, this facility, the ability of this facility to kind of choose which vaccine they're going to offer is really up to the facility. The other thing to know is that typically when we compare across facilities, these facilities are pretty similar in terms of their patient population. So if you compare the characteristics of patients at one facility to patients at another facility, generally speaking, they're not that different. And so what they ended up using in this study was the facility's choice for vaccine as the instrumental variable. So some facilities preferred the high dose and other facilities preferred the low dose. And so what they did was they used that preference as their instrumental variable with the idea that that's going to predict fairly strongly what vaccine somebody would get, purely based on which facility they went to. And the last one is selective Cox-2 inhibitors. So again, same kind of concern we have here. In pharmacoepidemiology, we focus on what's called confounding by indication a lot. And this is a problem of physicians prescribe drugs to people who they think are going to benefit from them, and they don't prescribe drugs to people who they don't think will benefit. And so the problem is that because Cox-2 inhibitors were known to lead to fewer gastrointestinal complications, there was some concern among the researchers that if we just look at who got Cox-2s and who didn't, that those who got Cox-2s were already going to be at higher GI risk than those who didn't. And so just using the assignment, Cox-2 versus not, you were going to have two very different groups. And so they were concerned about this and thought, is there something else that we can do? And so what they did was they did a study in using Medicare data where they had people who were 65 years of age and older. They identified those who were starting out on an NSAID. So this was either a Cox-2 selective inhibitor or just any other NSAID. And the goal was to use this study to look and see, well, what really was the difference in risk of gastrointestinal complications moving forward? And what they used as an instrumental variable was the prescribing physician's preference. So physicians tend to prescribe some drugs preferentially over others. Some were Cox-2 prescribers, others were not. And so regardless, the assumption was of what type of patient it was, if the physician really preferred Cox-2s, they were going to prescribe Cox-2s. If they didn't, they would prescribe a different NSAID. And so the instrumental variable here for this study was, what was the physician's preference? Was it a Cox-2 physician or a non-Cox-2 physician? And so that was their instrumental variable. All right, so now we've laid these three examples out. Now we'll start talking about, well, how do we go through each one of these and figure, are we really meeting these assumptions? Because that's the problem with instrumental variables, is if these assumptions are violated, really they're not a valid approach. And that's really where I think the limitations of this method exist. So the first question we have to ask ourselves is, do we have a strong instrument, right? We talked at the beginning, one of the critical first assumptions, and this makes sense, is if we're going to use an instrument, it has to be good at predicting our exposure, right? If it's not, then it's not useful to us. And so if we think about physician preference, right, we hope that if a physician's preference is Cox-2 inhibitors, that's what they're going to prescribe. And if it's another NSAID, that's what they're going to prescribe. So we need a strong instrument for any of this to work. So again, the stronger the instrument means it predicts exposure well. And so there's a couple of ways we can assess this. Right, typically, as I said, these are done as like two-stage least squares models to do these predictions. And so we can look at like the F statistic and the R squared to see, is this a good model to predict treatment or not? So that second equation that we saw where we tried to predict exposure based on our instrumental variable, we can ask the question, how good of a job does our instrumental variable do in predicting exposure? And we can kind of measure that using an F statistic or an R squared or something kind of like that. Another thing we can do is look at what we call the proportion compliance. So if we look at our study, how many people who had a physician who preferred Cox-2s actually got a Cox-2 prescription, and how many who had a physician who didn't prefer Cox-2s got something else. And so we can see how compliant the actual exposure was with our instrument. And that's another way we can kind of get a sense of, is this a good instrumental variable or not? All right? So this is one of the first key assumptions, and again, if it's not a good instrument, the rest really doesn't matter, because if you have something that doesn't predict outcome or exposure very well, there's no need to really think about the others. So there's a lot of issues with weak instruments, right? So the biggest issue that we get into is a couple of things. One, if it's not good at predicting our exposure, what ends up happening is the standard error of all of our estimates goes way up. And so what happens, and what instrumental variables struggle with, is if we don't have a good instrument, it becomes a very imprecise method. And so we get really wide confidence intervals, we get really large p-values, and so it becomes very hard to make sense of results. So if we have a poor instrument, if it's not good at predicting our exposure, that's one of the things we run into. Bias is also likely, right? So if our instrument's not doing a good job of predicting who gets exposed and who doesn't, the risk of a biased result goes up. And then the last one is another really important one, is if we don't have a strong instrument, the other assumptions suddenly become a lot more important. And so even minor deviations from the next two assumptions, if we don't have a strong instrument, can completely throw our analysis off. And so assessing how good the instrument is as a first step is really important. because all of these issues come up and become much worse if we have a weak instrument. And so we need to think about that as kind of the first step. So how is this done? So in the high dose versus standard dose vaccine study, they did a predictive model, and they found an F statistic of about 1,000. So that's reasonably good. The cutoff they recommend is like 10 or higher. Again, we know that F statistic is driven by sample size and affected by sample size, and so is the R squared. So you always have to kind of think about it a little bit in that way. But they also did just a model to see how good of a job does physician preference do at predicting exposure to a high dose versus standard. And they found, down here that it did a reasonably good job. And so in this study, they were reasonably confident that the instrument they selected, which was facility preference for either high dose or standard dose, was doing a reasonably good job of predicting actual vaccine receipt for our cohort members. For the Cox-2 inhibitors, they did it a different way, and this is where I talk about percent compliant. And so this was, what they did was they looked and they said, okay, for individuals, and I should back up for just a moment. So we'll talk in a little bit about, well, how do you establish physician preference? We can think of a ton of different ways to do that. And that's one of the challenges with that particular definition is, well, how do you define preference? The way they did it in this study was they basically looked and saw, well, what was the last drug the person prescribed? Was it a Cox-2 or was it a non-Cox-2? And that then was assumed to be their preference. And so what they looked at and saw here was that if an individual patient's physician's last prescription before that patient came in was a Cox-2, there was a 77% chance that that patient's prescription would also be a Cox-2. And so that's kind of trying to get at how well that instrument predicted. They also found, and again, this isn't ideal, but they found that if the physician's last prescription was a different NSAID, so not a Cox-2, they found only a 55% chance that that next prescription would be a Cox-2. So this was done at a time when Cox-2s are really popular, and so I think that's throwing this off somewhat. But what they see is, again, if the prior prescription was a Cox-2, there was a 77% chance that that individual patient got a Cox-2. If the prior prescription was a different NSAID, there was only a 55% chance that they got a Cox-2. So again, not perfect, but we definitely see at least some effectiveness of this method. There does seem to be a pattern where a physician who prescribes Cox-2 is more likely to prescribe a Cox-2 to their next patient. But again, there's a lot of concerns and limits with this, and we'll talk about those. The next question we have to ask, if we've found what we think is a strong instrument, is our instrument related to patient characteristics? Remember, what we're really trying to do is to kind of mimic a randomized setting, where we'd assume that those who are randomized to one group would be very similar in characteristics to those randomized to the other. And so the second thing we have to think about is it possible, right, that their patient characteristics differ between these two groups? And so the way this is typically done is to look and see, if we look at, say, different levels of our instrument between, say, preferred Cox-2s versus not, and look at patients in those two settings, we'd expect them to be fairly similar. We can also look and see, well, how different were they if we just looked at the treatment and exposure to see, are we doing better using the instrument approach or not? And so this method allows us to see, once we use the instrumental variable, are the two groups defined by that instrumental variable fairly similar, or are they dramatically different? And again, just like we've seen for other methods, this is done based on what we can measure. But again, the problem is, if we see imbalances in what we can measure, we can kind of assume that there's going to be imbalances in what we can't. And so this is typically done kind of your traditional table one, where we just sort of compare those in one level of the instrument to those in the other, and we see how balanced are they. One of the issues that comes up a lot in pharmacoepidemiology research, and I'll mention this here, is that because we're often dealing with claims data sets which have enormous numbers of people, when you're doing this kind of thing and seeing are there differences across levels, the p-value becomes a little bit shaky. And that's because we've often got thousands and thousands and thousands of people in each group. And as a result, even a small difference may trip a significant p-value. So they look at things like the standard difference as other ways to assess balance between the two groups. All right, so how is this done in the two studies that we looked at? First, this is the Cox-2 study. And so what I've got here on the left of this table one is, this is if we actually just forget about the instrument and we compare those who got prescribed a Cox-2 to those who got prescribed a different NSAID. And what you notice, if you look at this just quickly, is that these are very different groups. The Cox-2 group is older. They tend to have more comorbidities. They tend to have more issues with gastrointestinal problems and other diseases and things. They tend to have more prescription drugs. And so if we just relied on these two exposures, just those given a Cox-2 and those not, we're really comparing apples and oranges in a lot of ways. And so we need to see if we can improve on that. And so what we did was we now did this same thing, but instead we used in the middle column here the instrumental variable. And so what we did was we compared patients whose physician's last prescription was a Cox-2 to patients whose physician's last prescription was a different NSAID, and did the same comparison. And essentially, you can kind of think about these numbers as it's taking the percent in each group and subtracting them from each other. And so what you see is initially these really big numbers show, as we saw on table 1, that these were really different groups. However, again, once we do the instrumental variable approach, this middle, we see that the differences are much smaller. Right? We can look at this and still see, well, these still aren't the same groups. We still see some pretty big differences. And that's a problem here, and that's one of the issues we'll discuss with this instrument. But again, much closer. And so once the middle column, once they relied on this instrumental variable, and instead of using the actual exposure, they used what their physician would have preferred, Cox-2 versus NSAID, we see much closer alliance between the two groups. All right, so we can kind of see that in the middle here. So it does look like, at least in this example, that the instrumental variable, while it isn't perfect, it definitely improves balance between our two groups. Here's looking at the high-dose flu vaccine versus standard dose. So this is based on actual vaccine receipt. And so high dose versus standard dose. And this one was a huge study. And so you don't see the differences quite as clearly here. But what you do see just as a general trend is that those in the high-dose vaccine group tended to have slightly fewer comorbidities than those in the standard dose. And so this kind of aligns with the idea that physicians would often prescribe the higher dose vaccine to people who are sicker and the standard dose vaccine to those who are healthier. And so that's that concern of, well, are we really seeing an effect of the vaccine, or is it just the fact that sicker people got this one and healthier people got that one? And so that was, again, based on the actual vaccine receipt. If instead we compare the facility preference, so we've got, this is now looking at patient comparisons stratified not by what they received, by what the facility they went to preferred. So on the left, these are ones who preferred standard dose vaccine. On the right are the ones that preferred the high dose. And what we see is now these groups are pretty similar, right? So these are showing like percent with each condition in these two groups. And instead of grouping them based on what vaccine they actually received, we group them by the instrumental variable. Preferred standard dose, preferred high dose. And so we see that they appear to be fairly, a lot closer, or at least reasonably closer than on the original actual assignment. So at least in that sense, it looks like, yeah, we might have an instrumental variable that is reasonable here. The last thing, and this again is the most important assumption, and often the one that's hardest to kind of grasp, is our instrument related to our outcome? So remember, one of the really key assumptions is that our instrument has to be related to the outcome only through our exposure of interest. It can't be related to the outcome through any other pathway, either directly or indirectly. So the only way our instrument can impact our outcome is through the exposure we're trying to study. This is a tough one to test, right? I'll point out some ways that they've tried to do this, but it's not an easy thing to prove, is to know, is there some way, and we'll go through some other examples of instruments that have been used and kind of why they fall down a little bit with this one, is there some other way that the instrument we've chosen is affecting our outcome? So for example, maybe physicians that prefer Cox-2s over other NSAIDs, maybe they also prefer other drugs that are going to help a person's cardiac health. And so maybe that is, in that sense, those people who are prescribing Cox-2s preferentially, maybe they're treating people more aggressively, and so maybe actually they're affecting the risk in other ways. And so, again, this is a tough one to test, but it's important because this is often the one that is most problematic when it comes to an instrumental variable. How did they do this? Well, what they did was, this is for the facilities project, where we looked at high dose versus standard dose flu vaccine. And so what they did was they compared the characteristics of the facilities to each other. And what they found, again, this is on the left, is the facilities that preferred standard dose, and on the right is the facilities that preferred the high dose. And so what they tried to do is look at complexity in terms of the types of cases they see, quality of care across them, what region they were in, whether they were rural or urban, as a way to kind of indirectly see, is it possible that these facilities were different, meaning that somebody's care at a facility that preferred the high-dose flu vaccine might be superior to somebody's care who went to a standard dose vaccine facility. And so we see some issues here, right? They tested this using p-values, and they found nothing was substantially different, but we can see just kind of eyeballing it that it does seem like there are some subtle differences between the different types of facilities. So that makes us a little concerned that maybe we are seeing potentially a difference in our outcome between these two levels of the instrumental variable. So that's something we might want to be concerned about. All right, how about smoking and birth weight? So this one, we'll think about this one. I don't have the detailed results for this one, but we can think about this kind of as the different steps. And so remember, smoking and birth weight, they're interested in seeing whether mothers who smoked were more likely to have lower birth weight infants than mothers who didn't. And so what the instrumental variable they used was their original randomized assignment, where they randomized to receive the encouragement program or were they randomized to receive the control. And so that was the instrumental variable, that randomized assignment. So we can ask the three key questions for this one as well. Is the randomized assignment related to smoking status, right? So we'd hope so. If the encouragement plan was working, we would hope that people who were randomly assigned to receive this encouragement program would be less likely to smoke than those who didn't. And so we'd hope, at least in that way, if this was an effective program, that yeah, it would be in some way related to exposure. Is it related to other confounders? Again, remember, this is just a randomized process. Ideally, women are either randomly selected to go into the encouragement program or randomly selected to go into the other control group. And so if randomization works, we expect reasonable balance, both measured and unmeasured. So we assume if randomization was done correctly that, yeah, that the balance should be there. Is it possible that the random assignment, either the encouragement program or control, could influence birth weight beyond just its effect on smoking? And that one's tricky, right? Because we can think of why that might be a problem. We can think of the fact that maybe a woman who's strongly being encouraged to stop smoking might also pick up other healthy habits as part of that might influence birth weight. And so this last one's a problem, right? We can't definitively say that no, right? Because if somebody's being encouraged, even if the encouragement is all about smoking, it may encourage her or convince her, yes, maybe I should eat a little more healthy, maybe I should attend more prenatal visits, things like that. And so it's possible that those who are in the encouragement arm were more likely to do other things that would have improved birth weight beyond just smoking. And so this is a potential problem. And so this is the issue, again, with instrumental variables, is these assumptions are not always easily proven. And often almost always one of them, we kind of have to squint a little bit to see how it might not be an issue. And so this is another one where this last one we might have to worry about. So let's talk about some other common instrumental variables and the problems that they lead to, because while I think this is a method that has potential, I think almost every example of this being used in the literature, there's significant concerns about whether they chose a good instrument. One that is often used is distance to specialty care. So this is an example of this was they were looking at whether or not cardiac catheterization after a heart attack would improve outcomes or not. The problem is if they just use those who got catheterized versus those who didn't, the actual exposure, it's likely that those are two very different groups. And so that comparison isn't really fair. And so what they've done in some settings is use distance to a facility that prefers catheterization for people who suffered a heart attack as an instrumental variable. The theory being that if somebody's having a heart attack, they're going to go to the nearest hospital. They're not going to choose in that moment of an acute health issue, well, this hospital over here does catheterization, this one doesn't. They're going to kind of just choose one, whichever is closest, and that's going to be where they're going to get treatment. And so if it's a hospital that does catheterization, they're likely to get a catheter. If not, they're not. And so, again, this is the idea, that they assume that this distance would predict who would go to a hospital that preferred this method and who wouldn't, and so that distance was used as their instrumental variable, the assumption that it would predict which treatment they got. We can think of a lot of issues with this, right? We can think of distance could also be highly related to patient characteristics, which is where this one really struggles. Because if we think about, urban hospitals, the people who live in suburban areas are quite different from people who live in the rural areas. And so sometimes distance from like an urban center could be strongly related to socioeconomic status, other health issues. And so this method, this distance, is used not infrequently, but it's often tricky because we can't really show easily enough whether or not the distance is not affecting other stuff, other patient characteristics, which could also affect survival. Provider preference. We talked about this one already. This is our NSAID example, and also in some ways our vaccine example, where they try to use, instead of the actual exposure, what did the provider prefer? And the assumption is that providers have preferences. So some prefer to treat with a Cox-2, others prefer to treat with something else. And regardless of that patient's characteristics, you presume that if a person likes to prescribe Cox-2, that's what they're going to do. And if they like to prescribe other NSAIDs, that's what they're going to do. And so that's been used quite frequently. Provider preference is used probably more than any other as an instrumental variable. We run into some issues with this. And so one is, how do we define preference, right? We can think about tons of ways we could do that. One way that's commonly done is just look at the person historically and see, of their last 100 NSAID prescriptions, how many were Cox-2s? If it's, 75%, we assume that they're a Cox-2 physician. If it's, 25%, probably an NSAID prescriber. But again, we can think of other ways, right? The study we did basically, looked at the last prescription. So they looked at the last person who visited that doctor who got prescribed an NSAID before our patient of interest and figured out, well, was it a Cox-2 or a non-Cox-2 that they received, and that's what they assume was their preference. The problem with persistent prescriber preference is it's hard sometimes to adjust for changes. So physicians don't always stick to the same preferences, right? They hear things from their colleagues, they read articles, and they say, well, maybe I should use Cox-2s more, or maybe I should use them less. And so how to handle changes with time is tricky. All right, the NSAID study we're talking about tried to do that by using the last prescription as their predictor, but there's other ones that have been used, and it doesn't always lend well to predicting how preference can change. The other thing, and this is where, again, this method gets into trouble, and we can think of this for our NSAIDs example too. Patient characteristics can vary between physicians, right? Some patients who have severe gastrointestinal issues may go to a physician because they know he's a Cox-2 prescriber or she's a Cox-2 prescriber. And so that's a problem because if people who are sick and they have issues with their gastrointestinal tract, if they're preferentially going to a Cox-2 prescriber, then the whole purpose of this exercise has kind of been lost. The other problem that we get into is there may be other differences between those physicians that could also affect our outcomes. So in this Cox-2 example, maybe they're also, prescribing proton pump inhibitors. And so if they give out a Cox-2 prescription, they're more likely to also co-prescribe a PPI, which will reduce the likelihood of gastrointestinal problems. And so in those kind of cases, the physician is impacting the outcome, gastrointestinal issues, beyond just whether they prescribed a Cox-2 or not. And so you always have to worry, are these different physicians? And if they are, we're going to be into trouble with that assumption as well. So day of the week is sometimes used. This is a setting for looking at delay between an acute injury like a broken hip or a broken ankle, the delay between when the injury happened and surgery, and what effect that had on subsequent outcomes. And so the thought they had was, well, people who have to wait a longer time between when they break their ankle and when they go into surgery are going to have worse outcomes than those who don't. But if they just use the actual waiting time, that may be problematic because if somebody comes in with a minor fracture, they may get put off because they're not as concerned. But if somebody comes in with a severe fracture or other health issues, they may rush them into surgery a lot quicker. And so just looking at how long they actually waited wasn't enough. And so what they used in this study was essentially day of the week as an instrumental variable. The theory being that those who have an accident during the week are more likely to get surgery quicker than if it happens on the weekends. Because on the weekends, hospitals are typically lower staffed, different physicians are there, or maybe more people are coming in. And so the instrumental variable here was day of week. Again, we can think of problems with this too, right? So maybe the people who break their ankles during the week are different from those on the weekends, right? People during the week, if they're working, are in their offices. Maybe they're at low risk of an accident. Then on the weekend, they're out running around playing soccer and they break their ankle. So maybe the patients who come in on the weekend are different from those who come in during the week. The other problem we get into with this one is this idea of other factors that might influence outcomes. And it may be that there's different people working at the hospitals on the weekends. Maybe the surgeons are different. And so it may be that because of those other differences, the outcomes could also be better or worse. And so this is another one that's used, but again, runs into some trouble. Calendar year. This is another one that we see frequently used. And so it has its applications in a lot of settings, but we have to be careful here too. So the idea of calendar year as being used as an instrumental variable is that there are changes in what's prescribed over time. So medical knowledge changes, adverse events are reported, things happen. And so again, the idea is if we use calendar year as a way to predict treatments, that might be effective in some settings, because maybe in the 90s they would be prescribed drug A, but now in 2018 they're going to be prescribed drug B, regardless of their characteristics. It's just a change in sort of thinking. This was done, one study that actually used this quite effectively looked at the effect of beta blockers following hospitalization for heart failure and effect of that on all-cause mortality. And what's interesting about beta blockers is that for many years they were considered contraindicated in people who had a heart failure event, and so they were not prescribed. And then all of a sudden in the late 90s, there was a couple of large randomized trials that came out and showed, yes, that beta blockers actually might really help somebody with a heart failure. And then as time went on, the guidelines very rapidly changed. And so around 1990-2000, the guidelines went from saying don't use beta blockers to you should use beta blockers. And so what happened was there was this explosion of beta blocker use after this guideline change. And so what this study did was they used prior to that and after that as instrumental variables, with the idea being that if the person had a heart failure event in these years, they were very unlikely to get a beta blocker. And if it was in these years, they were much more likely. And so that was their instrumental variable. This really only works well for rapid changes like this. And so where suddenly overnight there's a change in the way things are done, which does sometimes happen, that can be a reasonable instrumental variable. And the problem gets into is if you have changes that occur slowly, other things are changing too. So sometimes the patients are changing, sometimes other care is changing, so other care is getting better. And so somebody who was having a heart failure in this time frame may have been doing better regardless, just because medical care is advanced. And so typically this method of instrumental variables using calendar year only works really well when there's this kind of sea change all of a sudden in what people recommend versus what they don't. So what does the instrument measure exactly? And so the key thing, and again, this isn't not, I'm not going to get into the statistics as much here, but basically the idea of it is we really measure two things. We have this two-stage model, right? The first stage is the bottom one, where we estimate the effect of the instrumental variable on our exposure. The second stage is that second model where we look and see what effect does the instrumental variable have on our outcome. But ultimately our goal is really to see, well, is our exposure related to our outcome kind of adjusted for instrumental variables? And so this is the equation that's often used, and it can be simplified if we think about a dichotomous instrument and a dichotomous exposure to look like this. And so if we think about this, the bottom is saying, what's the probability that somebody would be exposed if their instrument was 1? So what's the probability they would get a Cox-2 if they were physician-preferred Cox-2s versus what's the probability they would get a Cox-2 if their physician didn't? And so this bottom part is really just a reflection of how strong our instrument is, right? In an ideal setting, if this was perfect, it would be 1. Right? Because if the instrument was absolutely perfect, if a physician preferred Cox-2s, the person would always get a Cox-2. If the physician preferred another product, the patient would always get the other product, whether it's an NSAID. So 1 is the ideal, And as the instrument gets weaker, this denominator gets smaller and smaller and smaller, because what happens is the difference between the instrument in terms of what the exposure is goes away. The numerator is sort of kind of what's called an intent to treat type of estimate, where essentially based on levels of the instrument, what is the difference in our outcome? And so the idea here is to put these two pieces together to try to estimate, well, what really is the effect of the exposure on the outcome considering adjustment for the instrument. So just quickly, well, how does this work for, So this is, if we think about the smoking and birth weight example, this is the data they gave out. So we can think about in the numerator, our outcome was birth weight. And so what we compared was the birth weight in those who were randomized to the encouragement group and the birth weight in those who were randomized to the control group. So kind of an intent to treat analysis. The denominator reflects how strong is our instrument, right? And so that tells us, well, if somebody was randomized to the encouragement group, how likely are they to still be smoking compared to the control group? How likely are they to still be smoking? In this study, what they found was that those who were randomized to the encouragement group had babies that were about 98 grams heavier, and they found that in the encouragement group, 57 were still smoking at birth, whereas it was 80% in the control group. And so what they're able to do is kind of put this all together. This is, again, the intent to treat in the numerator, the difference in how well the instrument performed in the denominator, and what they found was they were able to show with this method that, yeah, stopping smoking really does have a strong benefit on birth weight. So again, assuming our assumptions are met, which is always the challenge. So we'll wrap up here. Again, what happened here? So high dose versus standard dose flu, what they found was when they used this instrumental variable approach, you can see that all of these ratios are less than 1. So they showed, once they used this method, that it does appear that the high dose vaccine was effective in preventing adverse consequences once they used this method. They included urinary tract infection as an outcome as kind of a way to see, is it possible that the facility's preference also affected the outcome independent of which vaccine they got? Because again, we wouldn't expect the flu vaccine to have any effect on urinary tract infection. And so if we saw that it was strongly protective against urinary tract infection, we'd be concerned that our instrument might be violating that third assumption. In this case, it looks pretty good, right? It doesn't look like the instrument has any effect on risk of urinary tract infection, so it offers a little more evidence. This is, again, wrapping up the Cox-2 inhibitors. In the last minute, they found when they did this that, again, we've talked about at the beginning how for the standard kind of cohort approach, they saw actually that risk of gastrointestinal complications was higher in those who got Cox-2s. But once they used the instrumental variable method, they found a lot closer to what they saw in the randomized trials, that they saw, it appears that this is a preventive, successful way of preventing gastrointestinal complications. So to wrap up in the last minute or so, again, I think these are our unique approach to identify and adjust for confounders. Both those we can measure and those we can't. Right? We have lots of stuff we can do if we can measure everything, but those unknown confounders become problematic. I think once you get beyond the assumptions, I think the method itself is relatively simple. SAS and R have procedures that can do this type of modeling pretty easily. So the concept and the approach is relatively easy. It's that assumptions that become really hard. And my take after, hearing these, working with them a little bit, is finding a really good instrumental variable is extremely difficult. And we often can never truly be comfortable that all those assumptions are met. And so I often say, maybe they may be better for like a sensitivity analysis, a secondary analysis, but because of some of these concerns about the assumptions, we really need to be careful about what we do and what we don't. So we need to think very carefully about, is it possible we're violating those assumptions, and if so, what might be the impact on our results? All right, so I offer some, some recommendations for references and things. These are some really good articles that kind of can lead to some other ones. Again, a lot of these are from pharmacoepidemiology because that's kind of where the method started. Well, really it started in economics and then it went to epidemiology. But these are some really good references, often written kind of in an epidemiology standpoint, so not a lot of statistics, that allows kind of to learn a little bit more about these methods. All right, so I'll stop there. I'll leave this up on the screen. Are there any questions, anything else? these are some good articles. I think the first two are a little better than the third one. I mean, they're really good, but the third one's definitely more technical. The upper two are more applied. So I think those are really, really nice.
I have questions, but I have to run. That was great.
Yeah.
So, you may have to repeat my question for the webinar people, but do the people ever use try to control for other variables when doing an instrumental variable analysis?
Yeah, so the question was, do they control for other variables when they do these? And the answer is yes. So that modeling equation that we saw that we tried to predict exposure, based on the instrumental variable and outcome based on the instrumental variable, you can do that either just as is, or you can include other covariates in there as well. So they will sometimes include other covariates in those equations. Any other questions? All right.
Any questions from our WebEx? No. Well, all right. Thank you, Scott.
All right.